Good afternoon from sunny and warm Central Michigan University. My name is Alison Smalley. I am a Constituent Engagement Officer in the Advancement Office here on campus. Thank you all for joining us today. We're very excited about this campus conversation. And I have a few housekeeping items before we get started, so I'll go over those quickly. We are muting everyone as they log in, not to silence you, just want to make sure we can avoid any feedback issues. Additionally, we would ask that you hold questions until the end of the presentation, or if you're like me and you're afraid you might forget it, go ahead and enter it into the chat, and I will be monitoring that throughout the campus conversation. Additionally, we will be recording this event and sending it out to everyone that registered afterwards. We will also include the slide deck and any other items that come up through the conversation that would be helpful for you all to receive. Lastly, I just want to say again, thank you so much. Thank you to Alison Arnold and Dr. Kikano for working so hard to help us put this together for today. So I will go ahead and turn it over to Dr. George Kikano.
Well, thank you, Alison. Good afternoon, everyone. I'm George Kikano. I'm VP of Health and Dean for the College of Medicine at CMU. I'm a family physician by training, and yes, I'm still practicing. I'm going to start by sharing some bad news for you, tell you how we got there, and hopefully give you some answers how we're going to get out of the mess we're in at this point. As most of you know, from personal experience, family experience, or others, as a country, we spend more on healthcare than any other country in the world. We spend more on healthcare than we spend on education, than we spend on jobs, than we spend on military. So healthcare is a major issue. Having said that, we have 1/3, yes, 1 out of 3 of the US population do not have access to the right care. What I mean by that, they don't have access to the right physician in a timely way, physicians or providers. They don't have it in the right location at the right time. So look at wait times, look at delays, look at hassles you and your family members go through. This started way before the pandemic, and it's gotten worse after the pandemic for many reasons. I'll mention some of them. As we speak today, there are 3 million healthcare jobs that are open. 3 million. You have over 200,000 healthcare employees. I'm talking in general. This is not physicians and nurses. These are medical assistants, these are LPN, these are phlebotomists, these are workers. There are over 200,000 healthcare workers still leaving their jobs every single month. So if you go, if you talk to the region and hospital executive, healthcare workers, academicians, or others, the number one problem they cite at this point is not Medicare or Medicaid reimbursement or fighting with Blue Cross. Cannot find people to work. And it's at all levels. So you have hospitals closing ICU beds. You have hospitals closing maternity units. You see how many maternity units, pediatric units just closed in rural Michigan in the past few years. This is not a reimbursement issue. It's actually a staffing issue. There's some light at the end of the tunnel, but things are still challenged. When you don't have access to care, it's not the individual they suffer themselves, their families, their communities. So people start seeking care at more expensive venues that are dehumanized for the most part. They go to the emergency room, cost goes up. They defer good care. Deferring getting a physical, taking care of your sugar, getting your eye exam. So quality of care as for population goes down, cost of care goes up, and communities suffer. Just maternity units and pediatric units throughout rural Michigan. And same thing happens in urban Michigan. So where you have densities, this is both a problem for urban America as well as rural America, which most of us forget about it. So I'm going to take it down to the physician piece as a physician here. We have my medical society called AAMC. They do workforce analysis on a yearly basis. This is based on projection, demographics, population data, retirement. So this is based on science. We're looking over the next 10 years to have a shortage of 124,000 physicians. This is across specialties. This is primary care, this is mental health, these are specialty services, and the data is solid. And when you talk to people in the field, it takes 10 years to produce a physician. So if you figure out from high school to college to medical school to specialty, you're looking conservatively at 12 to 14 years to produce a physician. So tomorrow's problems started now and got worse by the pandemic. We're all reading, what's happening with the nursing shortages. Things are much worse. We're looking by 2026 in the next 2 years, we're going to need 450,000 nurses to meet the demand, to meet the existing demand. As nurses retire, as other variables I mentioned in a second, to meet in the next 10 years, we're going to need 200,000 new nurses per year. Think about it for a second. 200,000 individuals, men and women, he, she, and theirs, graduating from nursing schools to meet the demand in 10 years. Bring it back to Michigan, bring it back to to physicians. Historically, if you look at Michigan, for 100+ years, you had 3 medical schools. You had obviously University of Michigan, you have Wayne State University, you had Michigan State, and MSU is the only university in the country that has both an MD and a DO program. What happened since 2000? The existing schools increased their class size, but more importantly, you added 3 medical schools in Michigan, and since 2010. Beaumont, which is now Cornwall down in Southeast Michigan, added new school. Kalamazoo had a new school, and obviously Central added a new degree. So you increase the class size of existing one, you double the number of medical schools, and you still don't have enough graduate. At CMU, our mission when we started is to produce physicians from Michigan for Michigan. And the demand is there for students. As a brand new school, we have a class size of 104 students. We have over 8,500 US applicants per year. So the demand is there. The slots are in there, even though with the increases. You see like medical schools popping up everywhere now. I'm just talking about the MD schools. You have a whole growth of the osteopathic DO schools, and you have thousands of US graduates, US seniors or graduates from colleges who, for some reason, cannot make it into US-based medical school. They go to what we call offshore schools. So you have medical schools in Caribbeans and islands that are for-profit. US graduates, they finish 4 years of college. They go spend 2 years in the island for year 1, year 2. They come back for clinical training year 3 and year 4 in the US for hospitals that we all interact with. So having said that, where the bottleneck comes are residency programs. The shortest residency programs are 3 years. They can go up to 7 or 8 years for students. So you look at the length of education to produce a doc. Having said that, 25%, when you go to the residencies, all medical schools go on one pool at the same time. So 6 or 7 medical schools in Michigan, the one in Ohio, Illinois, California, everyone goes through one pipeline, one system to see where these students get a train, what specialty, and this is coming up in 3 weeks for all medical schools. As a country, we are still importing 25% of physicians, what we call international medical graduates. So someone like me that grew up in different country, went to school overseas, we call them IMGs, international medical graduates. So as a country, we are still depending 1 out of 4 of us have an accent who went to school somewhere else. And this is what's taking care of the population. So it's a big problem. At CMU, by choice, not by need, we are admitting 2/3 of our students from Michigan by choice. This is mission for us. We also have seen a significant growth of our residency program. We sponsor residency programs in Saginaw. We have now up to 8 residency programs, 160 residents per year. What's most important, we're seeing our students either train in Michigan, stay in Michigan, go out of state, get the residency training, get their fellowship, coming back to Michigan, both urban and rural. So this is full circle mission for us. What led us there is very complex. We have something called the silver tsunami. The the largest population in the US now are the baby boomers. We are at the tail end of it. We're seeing the largest growth of population are the baby boomers. These are not the 0 to 18, 18 to 54. And as people live longer, they're living with chronic diseases. Their demand for services go up. We have so many advancement in healthcare. Technologies, procedures, surgeries, treatment of cancer. So people are requiring more services. As with more services needed, more subspecialty care needed, and the growing population, so the need for healthcare workers, physician, nurses aid, phlebotomists, the jobs are here, the jobs are needed, and as a country, we're not investing enough in this. The other piece of it, which is not much mentioned, it's the issue of healthcare. If you look at polling studies and national studies, one third of existing healthcare workers. This is happening for many reasons. The quality of jobs, working in the ICUs, working with understaffed units, the pressure of the chronic health record that brought in. So physicians in the office, I'm a practicing physician in the office. You spend more time interacting with the computer than you spend seeing patients now. The level of documentation needed, the messages you get, it's a constant flow of messaging and overload, creating physicians to burn out. Same thing applies to nurses, mid-levels at all levels. And unfortunately, there's stigma around physicians, healthcare workers, nurses, getting the proper medical care and mental health services and support they needed. The statistics for physicians is staggering. You have one physician suicide in this country per day. So as a country, we lose between 350 to 400 physicians per year to suicide from burnout. And at the end of the day, who wants to be treated by a nurse, by a medical assistant, by a staff in healthcare, or a physician who are burned out themselves? One other factor that's happening, which people do not pay attention to, is the violence against healthcare workers. If any of you have been in the emergency room in the past month or year or 6 months ago, look at the gunshots, knives. What the violence happening against workers in the ICUs. At all levels. This is the front desk staff in the ICU. These are the nurses in the back room, and ICUs are becoming overcrowded because there are no beds. So when you and your loved one are waiting for surgery, are waiting for an ICU bed, and your loved one is sick, this is creating a cruel environment. Just reading the news this week, Michigan last week, legislators passed a law against healthcare violence. So violence against the healthcare workforce is a real thing. Working condition is a problem. Hospitals are cutting staffing. So the nurses are not working at the top of their license, at every level. So you're doing more work that you're not trained to do. So the work environment in hospital are becoming problematic, pushing nurses and others to seek more lucrative, better, what you call travelers nurses. You've heard about them. So I'm going to go do the same job, working 12 hours out of state, come back, spend 4 days out, spend a week with my family, better pay. I don't have to be working in an environment that's not conducive to my training. So the working conditions have changed, pushing people to other sorry, my screen is acting up here, pushing individuals to seek other work arrangements. The interesting that's happening also for physicians is how subspecialized they are and how much more opportunities for physicians have that are non-traditional. It's not an office. It's not a physician in the office. It's not the traditional way of thinking about it. I have to, every chance I have to brag about my kids, I do so. Both of my kids, my son and my daughter went to medical school. My son, as a physician, would never see a patient in his life. He's just in his first job. He's reading images and working with medical AI, working full-time at a large academic center. and working basically remotely from home 80% of the time. This is the job he signed up for. So as a well-trained physician, he's never going to be interacting with patients, but he is in the healthcare workforce. On the flip side of it, my daughter, who's about to finish her third fellowship, is about to become a fetal cardiologist. So my son would never see a patient. My daughter will be working with fetal hearts that big, and so what she does. She's a pediatrician by training, but she's not gonna be seeing pediatric patients in the office. She's so subspecialized. My best friend does one cardiac procedure. So he's an atrial fibrillation specialist. Don't ask him about heart failure and chest pain. He's a cardiologist. He does just one procedure, that's atrial fibrillation. So you have all these factors coming together, creating that shortage at multiple levels. Some of them is how things evolve, other are not by choice, obviously. So as a country, this is a public health crisis. We need to address it. We need to address it now. There's not one answer. And tomorrow's problem starts today. We need to have all hands on deck to start addressing these issues. Some of the ways you address them is we need to stop looking at healthcare as an individual physician doing X, Y, and Z, a nurse doing that work in the ICU on the floor, a medical assistant working in a nursing home. Healthcare should become a team sport. So we need all members of the team. We need my nurse practitioners. We need my nurse practitioners, medical assistants, PAs, nurses, working as a team to take care of individuals, take care of families, taking care of communities. In a post-pandemic world, we need to work closely with the public health departments, locally, regionally, statewide, and nationally. Traditionally, there's been a big disconnect between public health and medicine. So the public health piece of the equation, the health piece of the equation should work hand in hand. Hospitals, clinics, we need to create better work environment, safer work environments for all our providers. More importantly, we need to show respect, show them that they're being appreciated at all levels. And we need to incentivize. And the big chasm happens in both urban and rural areas. Even in big urban areas where you have thousands of hospital beds, state-of-the-art equipments, hospitals, zip codes around these neighborhoods are completely underserved. I come from a place where we had one of the top 10 pediatric hospitals in the country. Top 10 pediatrics in the hospital. This is where you want your sickest kids to go. But the zip code around the hospital and that hospital had one of the highest infant and maternal mortality. Same thing applies to many urban areas where you have a cluster of large academic center, you have the best of the best, but the neighborhoods are not taken care of. Same thing is happening in rural areas. So the divide, the disparities, inequities that we see between urban, rural, and suburban is real. And there are going to be many more ways to deliver care that's different. Telehealth is here. Telehealth in the post-COVID world is not going away. So for example, there's one small VA in Saginaw, and you have vets who live between Saginaw North all the way to the bridge up to the UP. So the VA in Saginaw now has a full-time telehealth unit to take care of mental health needs and mental health needs of vets. There are many communities that don't have a psychiatrist. There are some counties with no psychologists either. So providing telehealth services. I was seeing patients myself on this past Friday, built in my schedules were televisits. So I did video visits in the midst of running a clinic. So this is going to be the way of the future. It's not going away. Remote monitoring on things. We're seeing more technology coming into homes. You can monitor someone's sugar, can monitor someone's heart failure, someone's condition. So using devices, remote monitoring, whether it's wearable or at home, is going to facilitate providing care at the right place at the right time using technology. And we need to be better capitalize on allied health, nurse practitioners, physician assistants to be able to provide the right care at the right place at the right time. So at CMU, we are working, we work with Urban Michigan. We have lots of affiliates throughout the state. We also, paying attention to what's happening in rural Michigan. And with that, I'd like to turn it over to Dr. Alison Arnold. Dr. Arnold directs the Rural Health Equity Institute at Central Michigan University, and she and I will be available to take questions after her presentation. Alison, I'll turn it on to you. Alison, you're muted. And I did it in 20 minutes, Alison, for the record. I just
Okay,
20 minutes to
awesome.
the point. Thanks.
Awesome. Good afternoon, everyone. And thank you, Dr. Kikano, for laying this important context for the work that's underway. I loved your reference to this is health and well-being as a team sport. And I think that as I have this opportunity to gratefully introduce the Rural Health Equity Institute today, I would like to share it's very much a team sport in the work that we are doing. And we team up with a lot of other very important outreach initiatives across CMU. I'll be mentioning some of those today, programs and partners within CMU that the Rural Health Equity Institute collaborates with. And I'm really pleased to share a little bit about its purpose and some of the program initiatives to give you some examples of what the Institute is working on. But in essence, we're to just deepen this work, this commitment from CMU, as well as our College of Medicine, to improve the health and well-being across Michigan, and to make sure that underserved communities get their fair share of resources as well. Okay, advance here. There we go. So I'm going to ask that you all kind of maybe put on your sunglasses and take a few minutes and just kind of think about the rural landscape. And Dr. Kikano already talked a little bit about the disparities that are unique between urban and rural communities. But in thinking about our state and Michigan, rural communities are really vital to the success of our state. 20% of our population in Michigan live in rural communities. That means we have 50,000 farms, 150,000 businesses, 1,400 local units of government, and 12 federally recognized tribal nations that are comprised and they live and thrive within our rural regions. And CMU is just one of 20 some colleges that are also residing in rural geography. So it's very, very important that we think about the workforce in our rural communities, because we are part of these rural communities as well. There's many examples of across CMU about how well we do rural, because we really have been committed and, as you know, surrounded by local regions who are rural. We all live, work, and play, many of us at CMU, in rural communities. But this is just one example of this idea now that health and well-being stretches far beyond medical needs of individuals and communities. And so when we are working through the Rural Health Equity Institute, oftentimes in supporting well-being, we find ourselves in initiatives that are focused on addressing other important facets of people's health and well-being in rural communities. I particularly love this particular chart that kind of shows some of these social drivers of health, because right at the middle is that sense of civic muscle and building that capacity within local communities. And I think that that's something that CMU is particularly good at, has been part of what we do for all of our work in outreach over the years. And we'll continue to begin to do that, to do our work as locally as possible, teaming up with the local communities to, work in concert to address what they identify as their priorities. And so health is also nested. And so we know that an individual's health, Dr. Kikano referenced zip codes in certain communities that we know are just, have much more health challenges than other zip codes, maybe just neighboring. But health is our individual health of children, of adults, is nested in the relationships in our homes, in our schools, in our communities at large, and even including our environment. And they change over time, as Dr. Kikano mentioned. In rural communities, we're seeing that, as Dr. Kikano referenced, the population is growing older by and large. And that means that there's a whole new set of chronic health conditions that often exist in rural communities. And the challenge in many cases Goes back to transportation in that prior chart, that oftentimes individuals don't have a way to get to services that are no longer nearby. And also we're seeing in rural communities that there are challenges of poorer families with lack of resources, and also the education levels in rural communities is something that we are trying to make sure that more of our rural residents have access to educational opportunities. And in Michigan, we're beginning to see a lot of things with access to tuition-free post-secondary options. So all of these factors matter. And this is kind of why our work of the Rural Health Equity Institute is really more broad in its nature, to align resources within our university and our medical school to support kind of this whole nested sense of how health and well-being is shaped in rural communities. And you see here, I like to use this particular chart because, it shows that, that health is nested in family matters. It's nested in a community that has either challenges or opportunities, and we've talked about that as well. But it's also shaped by environmental concerns, and increasingly, we've learned this from the ramifications of the pandemic. But in our state and throughout CMU, we're also focused on other kinds of environmental challenges, especially in agriculture, PFAS, and other kinds of challenges, water, safety as well, that we are working with communities because we know that that represents a important public health priority. Dr. Kikano mentioned physicians and the shortage of healthcare workers in our state. And one particular area that I'm going to choose to just reemphasize is the shortage of behavioral health workers across our state. We have a significant unmet need among our residents for mental health services support, behavioral health support that is going unmet. 2/3 of our advanced specialties in psychology, psychiatry are located in Southeast Michigan. So how do we make sure that we address that disparity as well in where these resources reside across our state? This is just a snapshot. This was actually taken prior to the pandemic, just prior, but it shows the unmet need for any kind of mental health service by region in the state. And so wherever you live, but we know where CMU is located on this chart, you can see that just surrounding us and all through our state, we have some significant needs. So the training up of the workforce is critical. Also, the deployment of all of our clinical expertise in internships and clinical placements, and that kind of intelligent collaboration with healthcare providers is something that CMU is really working hard on across not only the medical school, but our College of Education and Social Sciences and other colleges where these resources reside. But I'd like to share just some quick examples of some of the ways that our institute is focusing on 4 strategy areas to kind of help address these priorities and gaps. And the first one is improving access to care and resources. Dr. Kikano referenced that a lot of practice is shifting into telehealth modalities. And so we're trying to help build that capacity in rural communities across the state. We've got a couple actual initiatives underway where we are out working with rural providers to build their telehealth capacity. One is to help communities measure their true access to telehealth, because in some cases, the internet providers say one thing, the FCC says another, and then the true nature of it is people can't get the internet to even access their health platforms. Another one is a tool that we have built over the last several years, which I'll talk about, that is for healthcare providers, because during the pandemic, everything had to shift to telehealth very quickly. And many providers are still somewhat kind of adjusting to this new modality. And this tool for suicide prevention is something that we are really happy to make available to providers. It's part of a large CDC-funded grant initiative with the focused on reduction of suicidality in men. Men in Michigan represent a very vulnerable population, and particularly men in rural communities. So we built this toolkit, which provides lots of strategies and resources and tools for behavioral health providers themselves who are working with men in telehealth kinds of scenarios. We're also finding that this tool is really being well received by academic programs who are training social workers and other behavioral health counselors, because in many cases, many of these counselors are going right out from the frying pan to the fire, I guess, because of the workforce shortage. Many of these young professionals are being really put into situations for which they may not have a great deal of lived experience already. So this tool, it includes simulations and videos and resources to help stem that gap, so to speak. Again, other collaborators in this statewide project are other universities, University of Michigan, University of Maryland, Henry Ford Health System, our Veterans Affairs, as Dr. Kikano mentioned. So we're just really privileged and proud to be part of a pretty strong statewide initiative that will hopefully have a large impact on suicide reduction. I referenced briefly the telehealth broadband project. All these yellow counties that you see are counties that are designated rural, and John Jervinsky in our Rural Health Equity Institute is managing this initiative to go out and work with rural communities to really help them assess what their true internet capacities are, especially health services providers, and help get them ready. In Michigan, we're going to see the advent of a lot of funding coming to rural communities in the next year or so to improve their broadband capacity, and this will help inform communities to get ready for that opportunity. It's a national pilot, so we're exchanging and learning across different states, Alaska, Texas, West Virginia, and we're just really pleased to make this available through the Rural Health Equity Institute here in Michigan. Another thing that I referenced is the building of data and tools so that rural communities can really understand what is the nature of some of their health priorities. Many rural communities are starting to build their own dashboards. We have a wonderful dashboard through Mahia in our region here in the Great Lakes Bay. Communities in the northern stretches are starting to build their population health dashboards. This is a CDC-funded project that our institute has been involved with to build a dashboard on youth risk factors. So it has information from the youth behavior risk surveys and MyFi surveys in school that really provides a more current and regionalized information on adversities that our youth are experiencing. So this is a resource for regions to use as they begin to plan their priorities and community-based resources to support youth and prevent ACEs. Here's just an example of some of the professional education that the Institute has been involved with many partnerships. Very, very grateful for our partnership with the area health education centers, who also serve a broad swath of our rural needs for health career pipeline programs and education for healthcare providers in the field. And so whenever we can team up, that just seems to make the best sense. And over the last year, we provided a series of well-received symposiums and webinars for providers in the field on producing telemental health services and practices. And look for more. The AHEC is leading, and we're collaborating with some upcoming programs on human trafficking and so on. So there'll be more information coming out of that. And so, I just am grateful for today because I hope it begins to expand our thinking about health span and all the ways that we can think about the facets of medical services, community services, and all the ways that we can help communities to thrive if we focus on that health span all across the lifespan, working to support prenatal, perinatal, pediatric needs in our community, Dr. Kikano did not share, but in the last several years, CMU has really taken a leadership role in bringing pediatric resources to make them more available to communities around the state. Again, kind of making that shift from where many of the specialty resources have resided in Southeast Michigan. Again, also getting involved and thinking about those other drivers of health, partnering with our public health expertise in our communities and our community-based providers. We're going to see a lot more on community information exchanges so that healthcare providers and physicians can refer patients to community resources to help support their needs. And then focusing on healthy, active aging at every stage of life, children being active, thinking about what we do with our providing services and ability to serve our older patients in their homes, in places where it's not as disruptive to their lives or as medically costly. So thank you. I'm grateful for this chance to add on a little bit to the great information that Dr. Kikano shared today. And I'm welcome you to reach out to our institute, if we can work with you or if you have any questions. So thanks. I'll stop sharing.
We do have a couple of questions, so I will go ahead with the first question. This one is for Dr. Kikano. You mentioned that there are a lot of physicians and healthcare workers that are burned out and have lost passion for their professions. How do we as patients do research to make sure we are with physicians and staff that still have the passion for patient care?
Yeah, burned out is something. I mean, this is this is the EQ side of it. If you go and see a physician, physician, mid-level, nurse practitioner, PAs, and they're spending more time typing in that typing in that in the office, more no eye contact. Look at the physical cues for your medical assistant, your nurse, your NP, your PA, your physician. Look at their cues, the way they're looking at you. As a physician, I'm looking at emotional outlay of my patients. I'm looking at family dynamics as a family member in the room. As a patient, you should do the same for that. If your physicians spend times in the exam room, all what they're doing, looking at the screen and typing and transcribing, that's one, they're not paying attention to what you say. If you see them detached with no eye contact, with that language isn't there, you're gonna sense it as a patient. Same thing happens in the inpatient units, outpatient and inpatients. If your physicians, your mid-level are spending few minutes in here without being distracted, you have to look at the cues in the exam room in the hospital, and you're the best judge on the other side. The other thing that's happening is all the physician satisfaction and rating. If you look, most of them now, at least big systems, cannot speak up to small critical access hospital or others. They ask for patients' feedback, and these things are reported usually with comments. If you see someone with two or three stars there, that's a red flag.
Thank you. Additionally, for Alison or Dr. Kikano, either one, in the unmet needs map, it looks like the Great Lakes Bay region is the highest in the state. Why are we an outlier here in our local community?
Alison, you have to try.
I'll be honest, I'm not sure I can factually answer that question. That was an assessment that was conducted in 2019 for the Michigan Health Endowment. I will say that, again, I do attribute a great deal to the disparities where healthcare resources reside. And at that point in time, again, we've done a lot to break those barriers down. But we are continuing to grow our psychiatry programming, our clinics with outreach. And so I do think that, hopefully the need is still there, but I think that there has been very intentional work in our region to recognize and address that need. And other regions, when you look at them, in many cases, they may have satellites of some other medical affiliations in those regions as well. So I don't.
One other piece there is, while we have good healthcare, while we have outstanding institutions in Michigan, throughout the state, access is a problem. If you have a new employee that comes and work for your shop, manufacturing, CMU, SVSU, or others, access to care is a problem. If you try to find out your next available appointment for a primary care for preventive services, it's taking in excess of 6 months to see someone as a new patient. Access to specialty services is lacking in the region. So if you have a child with type 1 diabetes, where do you go? This is where the care is more sophisticated now, with insulin pumps, with continuous monitors. So access to the right care. Yes, you can get your antibiotics from the emergency room. You can go to an urgent care center, but that's not what we're talking about. When you need specialty services, mental health is a big issue. Primary care service is another issue, and access in Michigan is a problem.
Thank you. We have another question from the chat. The expected shortfall of physicians and nurses, as referenced by you, Dr. Kikano, is jaw-dropping. How will federally qualified health centers help us here in Michigan to meet our growing needs?
Federally qualified health center has special designation for outpatient clinic that for people who don't know that, they provide a whole slew of services that's very comprehensive. They have psychologists, they have social workers, they have patient navigators. So the value added of FQHCs in Michigan throughout the country is amazing. They're doing the best they can, but they are regulated by federal guidelines, by federal rules, where your office needs to be. They have some strict guidelines from the feds, but they provide the well-needed services. And we're fortunate to have many of them in our region. There's a great one, Citizens Health in Isabella County. There is Great Lakes Bay Health Center in the Saginaw and the Bay Area with over 20 locations. They are value added, amazing services. Quality of care is outstanding. We need more of them, not less.
And if I could just add on to that, just last week I was in a town hall meeting with my local state representative, and people were asking questions. It was a telephone town hall meeting, and someone asked a similar question, and it was astounding at the lack of awareness about what an FQHC is across the general community. So I think there's this opportunity. I know that there are restrictions in some of their guidelines about the patient care, but there is also a lack of awareness just across the population about the availability of FQHCs and what they can provide. So I think that that's a role that we can continue to play to help raise that awareness.
There's a comment in the chat that I would like to read. Hi, Danison. Danison says, 2021 CMU Master of Public Health alumni, currently in the MBA Health Systems Leadership Program here at Central. I'm grateful for the invitation to this conversation. Thank you for the effort of CMed Medicine under the leadership of Dr. Kikano, Rural Health Equity Institute under leadership of Alison Arnold, and everyone on the healthcare team, improving and reshaping the overall healthcare delivery in rural communities and sub-region.
Thank you. As I mentioned, healthcare is a team sport. It's not the idea that the physician is the captain of the ship, the physician is leading, is gone. It's a team sport. All hands on deck. You need the social workers, you need your mid-levels, you need your psychologists. It's a team effort to take care of patients. It's not one individual physician leading the charge at this point. And this is the way we need to approach it. For the better care of our patients, families, and the communities, we need all hands on deck.
To follow up that statement, Dr. Kikano, is there anything as community members that we can do to assist in this process?
Advocate for the communities. We have disparities in care in Isabella County. We have them in Saginaw. We still have them in Midland. Advocate for comprehensive care. Healthcare should be a right. We spend so much money as a country on it. The return of investment as a country for what we spend is not where we need to be. Money is not the issue. There's so much waste in healthcare that needs to be reformed. Advocate for what we all believe in. good access to quality care for everyone, irrespective of age, gender, orientation, rural, urban, and communities. I mean, for what we spend, we can do better as a country.
Thank you. I'll give everyone another little bit to think about if they have any questions. But before I come back to you all, I do want to remind everyone that we will send this recording out with the slide deck. And also there will be a survey if you wouldn't mind taking. It just helps us continue our virtual events. And additionally, I will also send a copy of the CMU College of Medicine annual report for anyone that would like to review that. Do we have any other questions from the audience? Okay. Again, Dr. Kikano, Alison, thank you so much for making the time to spend with us today. We learned a lot from you both, and we really, really appreciate all of your hard work.
Thanks for having us.
Thanks to everyone for their interest today as well.
Everyone enjoy your afternoon. Thank you so much.
Thank you.